Hello, everyone, and welcome to the panel session titled AI in the Hospital and Long-Term Care. My name is Tjaŝa Zajc. I work for a healthcare IT company, Better, and am the founder and host of Faces of Digital Health podcast. I will be moderating this session. In the plenary session, you were already able to hear in the introductory statement by Ms. Sophie Bossoir, the CEO of Corian. Unfortunately, Ms. Bossoir could not join us live, but we have three other speakers you will listen to. First, we'll hear their introductory statement, and I would kindly invite the first speaker, Professor Angelika Eggert, the Director of Department of Pediatrics, Department of Oncology at Charité Berlin, to share your introductory statement with us. Ms. Eggert, are you with us? Okay, perfect.
Okay. Thank you very much. I would like to share with you some thoughts about my field of expertise, and I don't see the... Yes, there are the slides. My field of expertise is pediatric cancer, and I'm working in a university hospital with pediatric patients suffering from cancer. And I would like to share with you some thoughts how patients have benefited so far from digital health, from data exchange, and from cooperation exchanging these data in the past. Next slide, please. First of all, some facts on pediatric cancer. So there are approximately 35,000 newly diagnosed cases per year in Europe. 6,000 of these pediatric cancer patients are dying every year, and cancer is in fact the leading cause of death by disease in Europe. 500,000 pediatric cancer patients, on the other hand, are survivors of the disease by the time of 2025. There are still a lot of inequalities in pediatric cancer care across Europe. So there is in fact up to a 20% survival difference in the European countries. Next slide, please. Pediatric cancer is a medical success story. So the current survival rate in Europe is approximately 82%. Next slide. And the reason for this success story, in fact, is found in cooperation, data exchange, and today also in artificial intelligence. So there is a long tradition of cooperation and data exchange in national and Europe-wide trials. There is and in these therapy optimization trials, there are shared clinical trial databases. In Europe, we have 21 European clinical trial groups under the roof of our society called SciOp Europe, and there are 33 national societies of pediatric oncology, all sharing data with each other. And in addition, there are national pediatric cancer registries, again involved in data sharing. Next slide. As a final statement, I would like to share with you three examples how this data exchange works. Today, there are so-called European reference networks built with the aim to deliver an appropriate cross-border healthcare in 57 member institutions in 18 countries. There is a virtual space for knowledge sharing. Also, a lot of patient and parents organizations are involved in this endeavor. And everything is built in an e-learning platform, and colleagues are given access to virtual tumor boards so that every expert in every country can learn from another expert. And there is currently a roadmap drawn to deliver European standard practice guidance. Another data example is the development of a survivorship passport containing electronic data on the patient's history, but also information on the need of follow-up care. Second example, the next slide, please. The second example is a real artificial intelligence platform where we do precise molecular diagnostics on pediatric relapsed cancer patients, and we collect a lot of big data in molecular profiling to enable biomarker-based basket trials. And meanwhile, this is at a level where pan-European clinical trials are conceptualized based on the big data that has been obtained in the past years. My final example, last slide, please, is a truly pan-European consortium that should have been a flagship in the European unit, but this program unfortunately was cancelled. But still, this is an ideal example for an AI ecosystem in biomedicine for the benefit of European patients. This is focused on an approach in cell-based interceptive medicine based on a lot of data obtained by single-cell approaches, and by using these approaches to identify a disease very early and to open opportunities for targeted interventions very early in the course of disease. So my take-home messages, the final slide, please, are that pediatric cancer patients are not just small adults with cancer. They have different needs in their data spaces. They have different cancer types, a different biology. They need different trials and different database logistics. There's also drug access problem that we have to address in the European Union. In the past decade, only 6% of 150 new anti-cancer drugs have been licensed for pediatric use. And in the European Cancer Mission, pediatric cancer data needs should be followed as suggested by our society, SciOp Europe. And I thank you for your attention and following me with this initial thoughts, and I'm happy to take question and discuss.
Thank you, Professor Eggert. I would now kindly ask Mr. Yann Le Cam, the CEO of Eurordis Rare Diseases Europe, to share his introductory thoughts with us.
Thank you very much. I will have, in fact, three perspectives to share. The first one is that we're all aware of the challenges and risk of extensive health data sharing and data linkage. But in our rare disease community, we have expressed now with a clear voice what is our perspective with regards to access and also granting access to our own health data, either for the primary use in healthcare or for secondary use in research. And this is thanks to a survey that we performed across Europe in 23 languages, and to which there were 2,000 responses. So what the survey says is that nearly 100% of respondents are supportive of data sharing initiatives to foster both research and to improve healthcare, but they want to keep control of the data they are sharing. And 80%, in fact, of them are even saying that are in favor of keeping a high level of control. So obviously, with that, we suggest to move beyond the valid consent to keep the patients, in fact, in control of their data and explore how patients can be meaningfully involved across the data cycle, providing them with the tools to understand the risk, express their preferences, and act upon their data in an adaptive way. In this survey also, what we learn is that 50% of respondents are concerned that their data could be used by a third party to which they would not have chosen to share their data. So obviously that takes us to suggest that we need to ensure that only relevant data is shared in a safe and secured way. So security by design, privacy by design is essential. My second message is around data sharing across borders to deliver care for rare disease patients, and that takes us to the European Reference Network already alluded to. These 24 European reference networks for grouping of rare diseases, covering all rare diseases, are primarily knowledge sharing and a care coordination platform they are also an infrastructure to produce new knowledge. So apply existing knowledge, produce new knowledge. Hence, the data sharing is at the core of this European Reference Network, of this new system, to share, to care, and to cure. This is why we called earlier this year for a comprehensive health data strategy for these European Reference Networks to transform the wealth of health data and collective knowledge into improvements to deliver quality of care and high quality. Real progress on rare disease and care and research are heavily dependent on our ability to pool and to combine different types of data from various sources and across countries. Indeed, we believe that member states can take advantage of this European Reference Network in shaping the future of European health data ecosystem by bringing together the different ingredients which are already there, a common goal to improve health outcome. The data are there from the existing sources, registries, natural history, outcomes, etc., and the trust between the clinicians and the patients who are already used to work together. My conclusion would be on the challenge and opportunities of artificial intelligence as a tool to support the care of rare disease patients. First, AI can power the diagnostic system, such as phenotyping of diseases with symptom checkers, which can assist for diagnosis. And indeed, Eurordis, Rare Disease Europe, co-founded with Microsoft and with Takeda, the Global Commission to End the Diagnostic Odyssey for Children with Rare Disease. And together with top academics from around the world, we are developing new tools using AI for the self-diagnosis with apps on the smartphones, but also to guide them in the healthcare system, to refer, and also to scale up the diagnostic capacities in the hospitals. Second, to design treatment plans, AI can power care pathways based on the analysis of large data set of patients, which would allow to risk stratify the patients and then to decide on the best course of action. That exists already for different rare diseases, such as in bowel inflammatory diseases. And there is overall, if I go beyond, there is a potential for a more important paradigm of change, in fact, in the long-term care, to make patients the primary points of care, to enable lifelong follow-up, essential in our area, building on the data of the patients rather than wasting it into different scattered boxes. 3, to better prevent the comorbidities. Data can really help to do that. With every rare disease, there is always a syndrome, there is always several comorbidities which can be prevented by a better management. And data are essential because they are the core of the collaboration between the different disciplines around the patients. But also to integrate more the health and the social data for a holistic care and management. We are really at the early stage for now, and what we need are 2 key success factors, and I will conclude with that. To assess and develop a comprehensive and strategic overview of the existing resources in rare diseases, databases, registry, natural history, networks of care. That's easy. A lot of this inventory is already done. But what is more challenging is to develop a federated data system that would enable to change the scale and to make amenable the machine learning and other advanced digital tools. And that's the very nature of rare diseases. It's a call for scientific and societal collaboration on an unprecedented scale. So we're working with the World Economic Forum into a health economic value framework for global data access for solving rare diseases. And also we've published a sensitive data in federated data consortium model in 8 steps. So we hope that the case of rare disease can help create a meta databases made up of consistent databases at local level that are transparently interconnected, but not merged for privacy and security reasons, but with robust and well-annotated data set that can contribute to country-specific solutions, to cross-border collaboration, but also to global solutions for diagnostic, for treatment, for healthcare management, and for the recruitment in clinical trials. Thank you.
Thank you, Mr. Le Cam. We have one more statement to hear, and that's from Dr. Esther Insa Calderón, Doctor of Nursing Sciences from the Escuela Superior de Enfermería del Mar from Spain. Ms. Calderón, please.
Good afternoon, and thank you very much for letting me to share my experience using new technologies in the healthcare sector. And I've worked as a nurse in hospitals and care homes for more than 10 years, but after that time I moved to a nursing school. And nowadays I work as a professor and I teach undergraduate and graduate students. And next slide, thank you. Next slide again, okay. As a teacher, I've always been concerned about how students learn. And one of the subjects I taught was human anatomy and physiology. I remember one day when I asked to my students what it was like to study anatomy, and 75% of the students say that it was rote, difficult, boring, and they thought that they felt lonely when studying. It's very, very serious problem. And even they say that they tended to forget what they have learned over time. Next slide, please. Next slide. Again, next slide. Okay, and for the reason, my colleagues and I started a project with engineers to create 3D models, anatomical models, and we create 10 anatomical models that let the teacher gather data about the students' learning activity. My experience is not more than another experience about how to use technology in health education to improve knowledge and skills in healthcare professionals, but there are other examples to use of technology, specifically artificial intelligence in hospitals, community care, and long-term care centers. Next slide, please. Let me give you some examples. In hospitals, for example, uses AI to predict diagnosis or to optimize treatment. Next slide. Hospital del Mar, for example, in Barcelona, has developed an algorithm that predicts the COVID-19 infection using chest X-ray radiograph and deep learning. Or, for example, in Calderón Hospital has developed another algorithm to identify the color of the liver and predict the possibilities to being transplanted. Next slide. And one example of community care is a scientist from University Pompeu Fabra University has developed an algorithm to prevent suicide. Because they, as is concluded by previous studies, people with mental illnesses tend to reveal their mental condition on social media and as a way to relieve, okay? And thus, a group of researchers create this algorithm to analyze the messages along a time of period of time and detect as soon as possible if this user is at risk of depression, and it helps to prevent suicide. And after its other example is in long-term care. Here, sensors are combined with artificial intelligence and help the nurses to control the movements of the client or patient. For example, when the patient moves and he or she is in risk of falling, or, for example, when the patient is with inactivity and she or he is at risk of pressure wounds in the skin, right? And this information is a lot of valuable for nurses because affect to the job of nurses. Well, I have also examples in different healthcare areas, but to conclude, I would like to highlight 4 opportunities of 4 potential risks I think artificial intelligence offers to nurses. Next slide, please. Next slide. Thank you. And like for opportunities, I see that artificial intelligence offers the possibility to have more efficient healthcare organizations. Nurses can offer a more humanized care, push up nurses to rethink their skills and to reskill continuously, and offers the opportunity to empower them. And like potential risk, I think one risk is the loss of nurses' job. I mean, some activities can be adopted by engineers or technicians and not in a collaborative way. And other risk is the loss of social value of the human. And the third one is the loss of taking care of the individuality. And also, it raises ethical issues, for example, related to accessibility of technology or the privacy of data. And thank you very much for your attention.
Thank you, Ms. Calderón. And I would like to continue with you to start the discussion. When the COVID crisis hit, we saw the surge in telemedicine and more doctors started working remotely, even those that work in hospitals. But what was the impact on nurses? So most of them, I assume, were still the frontline workers. But what about those that perhaps take care of chronic patients? Do you see the similar impact on nurses that can use technology as we've seen with the doctors?
Yes, I think the impact is the same. And we can find a diversity of experiences about that. And the communication and information technologies have made possible to define a new model of relationship between healthcare professionals, doctors and nurses at the same level, and the patient or client. And telemedicine enriched the attention opportunities without to replace the face-to-face relationship, but I think offer more opportunities. Even though for these patients with problems to get to the hospital or get to the community care center, right? But an additional advantage is for nurses because nurses with telemedicine can observe accurately to the patient. I mean, for example, nurses can assess the facial expression, the gait, the tone of voice, or the body position, or include the personal image of the patient at home. And I think it's an information that it's valuable for nurses. I think the impact is more or less similar like doctors.
Thank you. Mr. Le Cam, rare diseases are defined as conditions that affect less than 1 in 2,000 people. It's impossible to have an expert center for each disease in each country. And you and Professor Eggert talked a little bit already about the Europe reference networks. So cross-border collaboration is crucial in this case to build expertise. And Eurordis is a non-profit alliance of 932 rare disease patient organizations from 73 countries.
Right.
It's an amazing network. So what I'm wondering is, it sounds that because so many organizations are connected, that patients have good access to information no matter where they are, and they know a lot about their treatment options. What's the reality like?
It's still far from that. We've come a long way in 20 years, clearly, and as you kindly described this network, it's true that this has made a huge difference because the capacities of the patient groups of rare disease across Europe have really grown over the years, and there is a quality of information on rare diseases which can be found with the patient groups or with the treatment centers, or also on Orphanet, which is the fantastic European databases on rare diseases. But this is not sufficient. In fact, what we need to realize is that the definition is that one rare disease in Europe is 1 in 5,000. So that means less than 200,000 patients affected by one disease. And there is 6,000 different diseases. But the reality is that, in fact, among these 6,000, there is 5,000 rare diseases, which affects less than 1 in a million. So that means less than 500 patients across Europe, sometimes just a handful. So obviously, the gathering of the data, the gathering of the people is essential. We see today new patient groups being created not at national level. They directly start on internet for European or global group. And the same for research. It has to start now at that scale. And so all the cross-border collaboration and the pooling of expertise are essential to progress on the diagnose, but also on making even little steps sometimes, but on the care management, not to speak about treatments, because obviously medicines for these rarest diseases are extremely rare still now.
Thank you. We're going to touch upon the issue of medications and access a little bit later. Before that, I would like to ask Professor Eggert, in your presentation, you mentioned that there are up to 20% survival differences among countries. We have European reference networks for rare diseases. Could something similar help other conditions as well? Could artificial intelligence help change this divide between countries?
I'm absolutely convinced that this is possible because knowledge gain is always dependent on data sharing, and the rarer the conditions and the diseases are, the more important it is that we share our knowledge about it. And at least in our field, it works very well to share this knowledge, to get into networking, for example, to set up virtual tumor conferences between different countries, to share our expertise, to pool our expertise and have fruitful discussions. From my point of view, it's also very important to engage the patients in these processes and to build up their trust in these processes, because this is professional discussion, and right now they are not so much involved in it and not participating in it. And I think if we engage the patients themselves more, this is building their trust, because it's obviously not appropriate to have everybody travel to a different country to get a different kind of treatment, but more to ensure by these virtual networks, by data exchange, that the level of expertise can come to a similar level. And this is absolutely realistic and possible from my perspective.
What do you think are the main barriers countries that have worse results are faced with in treatment?
Well, sometimes it's a matter of drug access, and I think into this topic we will come in a few minutes. This is not equal across Europe, and also the ways of insurance, health insurances across Europe are not the same. So patients do not have the same access and to financing certain amount of drugs, but also the level of expertise in the different healthcare systems might still differ a little bit. Education differs, and also the resources that have been spent for healthcare differs quite a lot between the different European countries. And I think at least in part of the education, we can help out with virtual training issues, with virtual knowledge gain. This is possible, but of course in the different countries there also has to be resources for healthcare, and we see it now in COVID times. What happens if healthcare doesn't get sufficient resources?
Since we mentioned twice that we're going to talk also about drug access, I think it's best that we do so now. One thing that I wonder is some rare diseases can be treated with orphan drugs. So those are medicines that are expensive to develop because the number of patients are small. This means that the pharmaceutical industry, on the one hand, does not have a market incentive for drug development. And secondly, even if a drug was developed, it's hard to get a sufficient number of patients to participate in the trial. My question is, today, genetic data in combination with AI is making it easier for industry to find potential new drug targets. So, is the pace of orphan drug development accelerating in any way because of technology and the new data sets that we have available and will have available in the future more and more?
Is it still a question for me? Yes.
Yes.
So I think yes, it has already happened that these that genetics, big data, and the artificial intelligence analysis algorithms that are behind it have helped in trial design that is more biomarker focused today than just focused on, for example, common tumor entities. So right now we define a drug target, and then it is meanwhile absolutely routine to check in different tumor entities, and these might also include rare tumor entities for respective drug targets that are then treated in so-called basket trials in a similar way. And this helped a lot of the rare entities to benefit from drug targets that they share with other entities. And also there has been some progress in regulations because, for example, in the pediatric cancer field previously, it was sufficient for the pharmaceutical companies to state that the tumor entity they are aiming for is not present in children, but now they have to prove that the drug target they are developing the drug for is not present in pediatric cancer entities. That this is a substantial change and helps a lot to get pediatric trials also for the targets that are shared at least with adults, more common cancer entities. Yes, the short answer is yes. AI and genetics helped a lot to improve trial design also for rare disease entities.
Thank you. Mr. Le Cam, rare diseases are complex, so very quickly a lot of medical data piles up. How do patients take care of all this data? How much of it is digitized in your experience?
Thank you for the question. And if you allow me, I will start with a personal story, because which probably speaks for a lot of people in this community, is that I have three daughters, and my oldest one is affected by cystic fibrosis. She's 30 years old, and 2 years ago she was carrying an pregnancy. And thanks to fantastic doctors from different hospitals collaborating together, they saved her life by interrupting the pregnancy and then a few days later being able to do a double lung transplant. So we can only be impressed by the quality of the care, of the expertise, but also the quality of the collaboration between these doctors from 4 different hospitals to obtain that excellent outcome. And today she's doing very well. But the but is on the data. Is that now when she goes to the hospital regularly to speak with the doctors, and there are 7 of them in the pulmonary unit where she's followed, she sometimes has to restart to tell the full story. The full story in the same hospital service. Mm-hmm. Then she goes to see another doctor, which is a nephrologist in the same hospital, because she has obviously some damages in the kidney after spending 4 months in intensive care unit. And then she again has some time, she's seeing a new doctor, and she has to repeat the same story. And again, to go through all this period that she went through and to give herself most of her health record element. And when she goes to another hospital for the diabetes, because obviously with cystic fibrosis, you have diabetes with time, for the follow-up, then again, she has to. So in fact, the data are not structured, the data are not shared between the doctors themselves, even in their all Paris hospitals. So the technology exists potentially, but they just cannot do it. They don't have the time to do it. They don't know how to do it well. It's not shared. And it's not shared between doctor and the patient. So you have the patients taking notes in a computer and they're not sharing that. It's not annotated between them. So we're losing so much information, which is lost for her, but also lost for all the other patients. And it's clear that overall in rare diseases, this loss of data, the lack of data captured with a quality level and structured way is an obstacle to move up in the ladder of clinical excellence and on improving patients' outcome. So we have some exception. In cancer, for instance, it is better organized for some of the cancers, but not everywhere. And now, last comment is that on the average, a rare disease patient, either a child or an adult, has 8 different professionals around him or her. So if you don't have a proper data sharing, you can really derive how much you're losing. So there is a gap today between what the technology enable and what the culture and the tools are.
Thank you. I would like to ask a follow-up question to Professor Eggert. So I think this can be extrapolated to other diseases and other patients as well. So the fact that when a doctor sees a patient, he still prefers to hear the patient's story, the main things that the patient has problems with. So are we emphasizing too much this need for data connectivity if doctors in the end don't have the time to check all the data with the number of patients that they see daily, and they just want to hear from the patient what his main problems are?
Well, I think this has 2 sides upon it. First of all, I can very well see that this is a problem, and this also affects our everyday life. That data is not provided in a very efficient way. But it's not so much about data collection. I think what is needed are definitely electronic patient cards that provide us with an efficient amount of information every time the patient comes into the hospital. And I can imagine how annoying it is if the patient always has to retell the story again and again, and we have to avoid that. The most work that is implemented on us as doctors is not the work to collect the data and to share it, but it's the tremendous data protection regulations that we have to observe. And here we are in a field of unlimited bureaucracy that is really disturbing our everyday life. And of course, it is very important to protect private data, even more if it's medical data, but we have to find a reasonable way how to deal with these 2 demands, because if data security is so secure that nobody can share data with somebody else, then this is not what this is all about, and there has to be a reasonable way in between this. Yes, a reasonable amount of data protection to prevent misuse of medical data, but on the other hand, not to make it so difficult that it takes so much time to solve all these regulatory processes that data sharing is absolutely impossible in routine medical everyday life, because the patient really needs a more efficient process that is supported by electronic data sharing.
Mm-hmm.
Thank you. Ms. Calderón, let's talk a little bit more about the position of nurses, which are often left out of the discussions. We're facing a global shortage of nurses. To which extent can technology, robots, and AI aid this issue? Perhaps not to replace workforce, but just to aid them so we can decrease the pressure on the nursing staff. In the beginning statement by Ms. Boswart, we saw how Korean is already using technology to help nurses get an overview of the patient status through a platform perspective, platform view.
We have a very serious problem with the lack of nurses, and the cause of the shortage is due to a sum of multiple factors. For example, lack of effective healthcare policies, nurses' leadership, or lack of social recognition, etc. But answering your question, I think yes, technology can help to reduce the pressure of nurses, but only if the technological implementation considers some important aspects. For example, technology need to it need to be easy to use, right? Because technology need to offer more time to nurses, because this time is for be expended with the patient. And other aspect is if we are capable to use technology to give value to the human care. Technology, but itself is only technology, is an object. But I think we need to give value to nurses and the task of the nurses using this technology. And another aspect is if technology is accessible to every nurse. Nowadays, the technology is accessible for nurses from special services like ICU, intensive care unit, but not for, it's not a possibility for all nurses. And at the end, I think the last aspect is if we are capable to work in a multidisciplinary team. We work with other disciplines, but like a group, not like a team. And I think that it's basic. It's basic. Thank you.
Mr. Le Cam, what do current lockdowns mean for patients with rare diseases who sometimes need to travel outside their country for treatment? Do you see technology, telemedicine, and AI being more used with the shift to remote care we're observing this year?
Yes, absolutely. We don't have much data. We have only anecdotes from patients or parents about traveling to have access to care. We know that it has happened in some cases, but it's only anecdotal, so we cannot conclude anything. But what we can say is that we've done a survey across Europe, again, in 23 languages, during the months of April and May, and we had 7,000 responses. So that's significant to derive robust conclusions on the use of telemedicines. Before the COVID pandemic, there were about 25% of them who had some sort of experience of e-medicines, whatever it is. And now, during that lockdown period, so only 2 months after the beginning of the pandemic in Europe, there were already 50% of them who had experience. So it was doubling. There was a big jump. And that means e-prescriptions, some medical consultation online with their hospital doctor, and also a significant amount of therapeutic education online. And what is very positive is that there is over 90% of them which are highly satisfied with that possibility, but also with the utility of the consultation they had or of the tools online. So that's very promising, and we're pretty confident that it has continued over the last month, also over the summer and fall, to increase. And we really hope that new habits would have been taken, because one of the barriers before were the administrative burden that we were just talking about, all the bureaucracy on the top of that. No, it's not possible. No, you cannot do that. And then suddenly it became possible because of COVID. So we hope that a lot of these obstacles have now been addressed, and that it will relax a bit the approach for that type of innovation.
Thank you. We've got 9 minutes left, so I would like to present 2 questions we received from the audience. First one is, what is the progress of European health data space? And secondly, by the same author, all these transformations, especially in the public sector of health, need budgeting. What is EU going to do in this field? Perhaps Mr. Le Cam or Professor Eggert, are you familiar with any of the plans on how to solve the issue of funding with the progress of the plans for the European health data space?
Well, I'm only familiar with the cancer field, and of course, the European Cancer Mission will open opportunities to fund AI and data exchange and data space options. There will be hopefully a centralized digital cancer center to collect a lot of the data across Europe, and hopefully there will be also similar activities for pediatric cancer patients, because these have different needs, as I pointed out. But what we also need are some kind of AI ecosystems in the different national countries, hubs where certain developments also in the field of new omics technologies are fused with artificial intelligence options, and provide first proof of concept how this can be used for the benefit of different patients. And this we need, of course, in more diseases than cancer. And I hope that there will be some fields in the European Horizon 2020 budgets and the future budgets to make space for these AI activities and endeavors in the biomedical field. This is what is certainly needed. I absolutely agree. And we cannot provide this money from the mere routine healthcare, because this is already at the limit of what is possible.
Thank you. Perhaps, Mr. Le Cam, you can add something. Also, looking from the experiences with European Reference Network, what can we take from that to the whole idea of the European health data space? I think you're muted.
Yes, I was.
Okay,
Is it better? Oh, okay.
Thank you.
Sorry about that. Yeah, I completely second the comments of Professor Eggert on this matter. What I would add is that the EU has really cards in its hands when we think particularly on global competitiveness, right, and attractiveness for research. But we're not powering that enough. So I mean that we hear a lot of innovation here from cancer or what Esther was describing in Barcelona and Hospital del Mar, etc. They are really fantastic innovation. But we don't have really the ecosystem. We're lacking partnership between private and public. We're lacking partnership between public and public, co-funding between regions or local entities and EU funding. We also lacking a policy framework for rare disease to really power all these possibilities for the next decade. And the funding is an issue and need to be scaled up, that's clear, in this area, which can be highly innovative. But what it needs first is a policy framework and an openness to more partnership of this kind. That's really what I see as lacking in this area. And clearly, the European Funds Network, as you refer to them, are a good place to start with, or a good place to go to create such new federated, aggregated data sets of databases in order to, on this base, then to be able to develop AI and other tools. So the potential is there, but we need to be careful because it's moving fast, and if we don't put in place all the systems, so what I can sense, really speaking from the patient perspective, is that the patients and the society, somehow the citizens, are somehow more ready. There is a higher readiness than from some of the decision makers. We saw that in our experience with the European Funds Network. There is a system to share files and discuss patient cases across borders called the CPMS. And one of the lessons, there were several, but one of the lessons we learned in that process with the European Commission and all the member states is that there was we didn't engage enough the hospital managers. And that they are key. So it's that kind of things, is that we need to investigate, people need to part of this movement because we are very much into public healthcare systems and into public funding, which is sometimes a weakness, but in this case, it can be turned into a strength because it's protecting the people and because it can be really focused on improving health outcomes. And it's not for profit, so all that. So there is also a trust from the public. So there is a lot of positive elements, but we need to make it more dynamic for the uptake of these innovations.
Thank you. We are almost at the end of this discussion, so perhaps for some final words, Ms. Calderón, what would your wishes be towards the EU policy future? Perhaps a message to EU policymaker from your perspective, from perspective of nurses.
Well, it's a difficult question, but I was listening to Dr. Yann, and I agree absolutely with him about we need more collaboration and the fundings. We need to find more partnership without organizations and institutions, because in other way the innovations, it's like isolated, right? And maybe one policy can be to facilitate these partnerships and to push up the institutions to share data or data and innovations, because in other way we repeat the innovations and we spend money separately, right? And for nurses, we need different things. One of them is we need to empower to ourselves and to learn to develop soft skills and digital skills. And to institutions, I ask for to let the nurses to have enough time to be with patients, because sometimes they need they don't have enough time to be with patients, to learn a technology, to take the administrative task, right? And it's too much, and it's a serious problem, but it's different things. But thank you for the question.
Thank you. Perhaps just before we part, Professor Eggert, just quick response from you about a statistic that I found very optimistic. Today, there's an 80% chance of curing childhood cancer. In the 60s, that rate was only 20%. How did we get here, and what does that tell us about the future?
Very briefly, we got there by collaboration and by data exchange, and that certainly is also the way to the future.
Thank you. And with that, I would like to finish with this panel. Thank you to all the panelists for sharing your insights and thoughts, and to all the participants. Enjoy the conference, the short coffee break, and then the final and main part with the large panel discussion with the top decision makers from the Europe. Thank you.
Thank you to you.
Thank you. Thanks.
Thanks.